children in utero whose mothers had low progesterone had lower IQ scores. You just said that Katharina Dalton used her scientific experience and her understanding of how PMS impacts the female brain to defend women who had killed their husbands in court and won.
The information shared on the Rethink It podcast is intended for educational and informational purposes only and should not be taken as medical advice. While Dr. Sande is a licensed medical provider, the content of this podcast is not a substitute for professional medical diagnosis, treatment, or advice specific to your individual health needs. Always consult with your healthcare provider before making any decisions related to your health or medical care.
Welcome back to the Rethink It podcast, where we challenge what you think you know about brain health, longevity, and healing. We are not here to chase symptoms or hand out quick fix Band-Aids. We're here to ask better questions. We're here to rethink pharmaceuticals as the first answer, explore cutting-edge natural sciences, and most importantly, we are here to employ you to partner with your body's innate healing wisdom. Well, welcome to the Rethink It podcast, Carol Peterson. I am so glad you joined us. This is an amazing and timely podcast for me. I'm so happy to talk on the subject of bioidentical hormones because it's a huge piece in brain health, especially in women's health, which is a big thing I'm leaning into, why I talk about anesthesia, because it highly impacts women's brains. It does impact other people's brains. Men are also affected, but this is a big women's health thing. And the interesting thing we're going to find out is that bioidentical hormones have a place for men too, so we're not leaving our guys out here. So this is going to be a very good conversation, and I'm so glad you're joining us because you have the experience. Carol Peterson, tell me about yourself. How did you, tell me your background. How did you get here?
So I'm a pharmacist, actually, and you would think that's kind of odd. I say renegade pharmacist sometimes. It did give me a good, solid background on a lot of things, a lot of chemistry, biochemistry, physiology. And you know what's really kind of interesting, you probably agree, as soon as you leave your pre-courses, which are supposed to help you with your professional courses, all of a sudden you're expected to erase everything else that you learned, how the body really works. And now you're given just flowcharts, if this and that. And it's gotten so bad that practitioners can hardly think outside a flowchart, which I think is leading. It's leading to some very, very big problems. So for 27 years, I worked for a compounding pharmacy, and it was really a blessing. I found that every single thing I had done in my life seemed to have a place in this new place. And what was happening at the time, this was in the late 80s, early 90s, that Dr. Katharina Dalton's work in England had come across the pond, and pharmacists and pharmacies were emerging who started to use progesterone in compounding. Katharina Dalton's work was mostly focused on severe PMS. And she not only identified this syndrome and had a whole list of what goes wrong with this premenstrual type of really severe mood issues and physical issues. And strangely enough, she had measured progesterone in these women with these symptoms, and they were quite normal. Yet she realized that they were in the luteal phase where progesterone is supposed to be very dominant. And she used progesterone, made that leap, both for herself and then for her patients, made the leap that progesterone was really, really effective for these very, very severe symptoms. even so, she got women off who killed their husband. For instance, she published a book on her court cases because women could get so irrational and dangerous during the luteal phase, and she could overcome that.
You just said that Katharina Dalton used her scientific experience and her understanding of how PMS impacts the female brain to defend women who had killed their husbands in court and won. Is that right? Oh
She
my
won.
God. That's crazy. Okay, so there you go. Is she the one that wrote Once a Month? Is that
Yes.
that book? That's her book?
That
Okay.
book, yeah. In the United States, several pharmacies got busy compounding progesterone suppositories, which was her favorite mode outside of injectables that she could use for those patients. And the doses in those suppositories was 400 and 600 milligrams and used multiple times per day.
Wow.
So
Wow.
we are really stuck in the U.S. We have this kind of conventional wisdom now saying because of the approval of Premestrual, progesterone in oil capsules, a while back, it was approved for protecting the endometrium, and 200 milligrams was the dose. And this is like filtered into our thinking, and even functional medicine doctors are like, they're too afraid to go up over 200 milligrams. Like this is the top of Mount Everest and there's no place else to go. But not true. And it's a good thing I know this because we've kind of lost touch with how beneficial progesterone is, and there's so many symptoms related to low progesterone that are not getting recognized. And what's going on in the brain is a big one. It's
The massive one, yeah. Did you?
it's
So were you had worked in? Were you always in a compounding pharmacy? What was the like your career trajectory? How did you start? Where did you? And how did you end up now being, speaking? I call you the progesterone expert. The voice of progesterone.
because I'm unfailingly saying this is the problem. I was on a Facebook page, and somebody said to me, "Don't you know anything except progesterone?" And I said, "Oh, I'm happy to talk about other hormones." I said, "But nobody in this group has enough progesterone." Just
That's hilarious. That's so true.
it is. So it's fundamental. It's fundamental to everything else. So before that, I'd worked in a hospital a couple times, and I worked retail pharmacy, which actually is not so bad, except we don't have good solutions for people. But I love working with people. And so I really learned a lot from that experience anyway. Then I went to a big clinic pharmacy. I was head pharmacist, and I had nothing but really politics, where now we're supposed to limit any discussion with a patient to about 30 seconds because it was so busy, nobody could talk to them.
And this is Canadian because you're in Canada, correct?
No, this was in Wisconsin, actually. I'm from Wisconsin.
In Wisconsin, in the retail pharmacy?
Yeah, this was a clinic pharmacy.
In a clinic pharmacy, you were instructed to limit your conversation to less than 30 seconds with a patient. Oh my gosh. Okay, so listen. So many of the people on my socials channel is like, well, why don't they tell us any of this? Why don't they tell us if there's a side effect from, this drug and that drug? Why? This is malpractice, You're being instructed to spend no less than 30 seconds. The doctor literally has less than 5 minutes. Where is the education going to come from? It really is an issue. It's an issue systemically.
Yeah. And the other problem is that this whole issue of endocrine disruption, whether it really starts during your pregnancy. If you're not at optimal progesterone during pregnancy, you're going to have a baby that's not thriving and colicky and going on to ADD, ADHD, and then PMS and PCOS and infertility, and then severe perimenopause and menopause
So what
symptoms.
you just said, I'm sorry, this is like gold. This is really important. And I think Katharina Dalton, she does a great job of explaining this. Her book is not very thick, and it's very good and like giving you the nitty gritty. It's a little dated because it's older, but it's wow, exactly
She's
what
still
you said.
right.
She said children in utero whose mothers had low progesterone had lower IQ scores. They were born with lower IQ scores. And to me, it was like a light bulb because I remember in medical or in PA school going through OBGYN and learning, you know, the 35-year-old and older woman is considered geriatric. Just a cool word to use on a 35-year-old woman. But, and they were saying that they had higher risks for, you know, all I knew was that after 35, you had a higher risk for Down syndromes and neurodevelopment and developmental issues with the children, and the mother had more risk for preeclampsia and those type of things, complications.
Yes. Oh, exactly.
Light bulb went off when I read her book, and I was like, it's because the progesterone starts to decline at 35.
Hello.
They didn't tell us that in school. I didn't read that anywhere. Nowhere was that connected for me until 25 years later. And I'm picking up this book or 20 years, I guess, picking up this book and going, it's the freaking progesterone. Oh my gosh. And so then the child is impacted. And like you said, it's just this cascade, right?
Yep. It's not genetic, it's generational. And things that can deplete progesterone, of course, is aging is one of them. But we have incredible stress in our society today. We have our air quality and food quality and water quality is all compromised. And we have such political stress going on and COVID stuff going on. And so what's happened is that our progesterone just gets used up too quickly. And it's a backstop for cortisol. When we are stressed, our cortisol goes high in addition to adrenaline. But then over time, we fail to make enough cortisol. But in the meantime, cortisol production has pulled from progesterone, pregnenolone, maybe even from cholesterol to try to fill that all in.
Is this what you're talking about? The cortisol steal, where we're creating the cortisol demand that we have steal from progesterone because of the way that cortisol is produced. It's produced from pregnenolone, and we skip making progesterone to make the cortisol. Is that what you're saying? Sorry.
Yeah. It's also called pregnenolone steal, although people don't say it. But for years in my working with this, I always would say progesterone will help fill in cortisol.
Yes.
And then I was told by a physician who got it from a man who runs a hormone testing lab that progesterone is not converting directly to cortisol. And I go, oh, and I did a deeper dive and I go, sure, it's 3 metabolic steps that we aren't tracking that takes us to cortisol. And astonishingly, pregnenolone is 1 step away. So I've become quite a fan of pregnenolone dosing too, and rather high dosing. And talk about an important neurosteroid. This one, pregnenolone, really concentrates in the brain and has a lot to do with focus and concentration.
Yes.
Huge. When I was working at the compounding pharmacy, I had a call from somebody who was writing an article. And she said to me, what do women complain about the most with their hormones? I said, they complain that they're losing their mind. And she said, no, they're worried about breast cancer. I said, no, they're not. It's their brain first and foremost. And it's absolutely astonishing. You find the most competent female leaders and whatnot, and they come to this point in their life and they're struggling and they're really just short on their hormones are declining. And
I feel it in my bones what you're saying. I remember that cycle starting for me at around 38. I literally felt like I was becoming bipolar. I was like, what is wrong with my head? Like, what is going on in my mind? And then I couldn't detox and I started to gain weight and I couldn't sleep. It was horrific.
yes, it is. And the trouble is we don't have enough information out there. And this is what the internet is doing for women and men too. And podcasts like yours, people are hungry for information. And the most blessed thing out of all of this is when I'm working with people, they have to take charge of themselves. And they're not going to get the answer from one person. They might need multiple experts, but they're the clearinghouse. They have to decide, is this for me? How am I going to do it? How am I going to incorporate it into my life?
The shift of power is going in the right direction.
Yes.
In my book, I kind of talk about this, about you. I call it you being the CEO of your health. You being the one who has the power in your health. And to do that, that means that you have to know. Like, you have to know things. Like, you know, it was Peter Attia had a great quote about that. Like, you just have to have some basic understanding of the problem so that you can be a troubleshooter in your own health. I mean, he said something really much better than that, but that's the education. I know I've gotten a little bit of pushback online because I've been talking about the impacts of anesthesia on the brain. And then people are like, well, now I'm scared. And let me tell you, as an anesthesia provider, that is hard for me because our bedside manner and one of our primary goals, if you're good at your job, is to walk in and your surgeon has just left and the patient's all freaked out, and walk in and bring the energy and the freak out down. Like, I don't want freaking people out. But if you don't know there's a problem, how can you possibly advocate for yourself? Do you know what I mean? And that's the thing. And I think that's what you're driving that point exactly home. Like, we have to have this conversation.
That reminds me of a client over at the compounding pharmacy. And she called and she was in pain and she had several surgeries for endometriosis. And she was afraid to go into surgery again, but she was in such pain from adhesions. They were going to take care of the adhesions. And I said, you know what you ought to do? And I said, I worked in hospital at one point. They used to, but I don't know if they still do. They use something called Solu-Cortef. And they pre-treated a patient with hydrocortisone, your main adrenal hormone. And so why don't you ask your anesthesiologist if they would administer that for you? And I said, it's going to help you get through the surgery and the recovery much better because you have the hormone to count on. So this woman did do it. She didn't contact me for 3 weeks. I thought maybe she died. I was getting worried. But no, she said it went really, really well. And she said, she had progesterone too. She said I had my bottle of progesterone in my hand so I could call the number if I needed to.
Wow. That's hilarious.
I know.
So let's talk about progesterone, because you've already kind of given an amazing intro, but there's so much more to the progesterone story. So talk to me about what progesterone does. Let's start at the cellular level, because cell science is my favorite.
So, well, interesting enough, and I don't always know that we always have the truth of things for everything. So when I'm talking about this, I am kind of repeating what I've heard, but as it evolves, things have really changed. We have such a focus on hormones are created by a certain organ and they go into your bloodstream from that organ. And we have an immense focus for women on ovulation and nothing else. And it's because after ovulation, in the luteal phase, progesterone is produced in massive amounts by the corpus luteum when things are going well. But nobody's paying attention to the first part of the cycle, where progesterone's still there. And if you look at the graphs of the menstrual cycle, they'll always have progesterone way down at the bottom, like it's not important. But that line needs to be moved up 1,000 times vastly over estrogen. And then we have some idea of the relationship. So the follicular level of progesterone is entirely ignored. So where's that coming from? Well, that's coming mainly from the adrenals. It could be other sources. The brain independently makes progesterone. That doesn't go into it and used. And the nervous system cells,
So
the
it
Schwann
means that
cells.
it uses it, it doesn't go into circulation? Is that what you just
No,
said?
it uses it there.
Hmm.
So you can't measure that. The mast cells independently have the whole steroid cascade, primarily from DHEA, but it can make every hormone right inside that little cell. If you happen to have not enough progesterone, estrogen dominates right inside that cell, and the consequence is you get a load of histamine being released.
I.e. mast cell release, i.e. mast cell syndrome, i.e. POTS, i.e. hives, itching, rashes that start to increase. If you're perimenopausal, please tell me you feel me, because I'm telling you, dry eyes, itchy skin, rashes, those things are like the things that we don't connect to our perimenopause, right?
Okay, so with the cell biology, we're kind of locked into this key and lock idea that you have a hormone and you have a receptor, and it fills specifically the right way when you have the right hormone, and you get the benefits of that interaction, and you get the effects of that hormone. And they say like most of that occurs in the cell nucleus, that the hormones have to get into the cell wall, into the nucleus. And then we found that there's receptors on the cell wall as well. And then we find that there are, they call it non-nuclear activities of progesterone, for example, has things it does all over the body, not requiring a receptor. So the science is evolving. So what's the truth of all this? I'll tell you what I know, just like clinically. If you use progesterone and you use enough for your needs, all symptoms of progesterone deficiency disappear. So progesterone does act like a antihistamine, like we were just talking in the mast cells. It prevents that dumping of histamine in the first place. Then it also balances adrenaline. If you have high adrenaline, it can serve, whether it goes to cortisol or not, I can't say, but it will offer a balance to enhanced adrenaline as another activity. Even though your brain is producing progesterone, if it's not enough and you don't get any calming effect from the GABA receptor, you can use progesterone and your brain will use it. It will. You will have a conversion to allopregnanolone, and it will sit on the receptors in the brain, and you'll get a result. So it's a bit complicated, but your body makes it, and your body will use it if you use it externally applied.
Hey guys, I wanted to pop in here in the middle of our episode just to remind you to pick up Stephen's book about Lyme disease. It's called Kids Get Lyme Disease Too, One Boy's Story About Trusting God Through Lyme Disease. This is a book, even though it is a children's book, with beautiful illustrations for kids and written in language that kids can understand. I want you to see these illustrations. Amazing, right? those illustrations are amazing, and the book is written in child's language, but it is really one that is designed for anyone to pick up and anyone to be encouraged by. The reason Stephen wanted to write his story is not because he wanted to draw attention to the fact that Lyme really wrecked his life at a young age and gave him a really difficult time. Made it hard for him to walk and play and all the things that kids do. But he wanted to show that his journey of what he learned about himself, and most importantly, what he learned about the Lord through his journey through this process. And he was very proud of it. He just really wanted everyone to hear. So this book was written by both of us, but it is his story and his story to share. So I really want you guys to pick it up. And if you have picked it up or are picking it up, please make sure to do a review on Amazon. So you pick it up, you're a verified purchaser, please give me some stars. I don't care if they're 2 or 1 or 5, but just give me something. And if you can, even better, would you just leave me a note in there and tell me how it blessed you or how you hated it? Either one. I would love either of those, preferably if you liked it. And the other note I'm going to make now is just to let you guys know that my other book, my book is coming up, my baby, that I've been working on for, I would say, 2 years. It's been brewing in my brain, and the research has been going on for that long, for sure. Pen to paper started in January of 2020. The research and the citation references and everything has been going on long before that, at least a year before that. So I want you guys to pick that book up when it goes live. I just want you to be looking for it, excited about it. The book is called The Quick Way Back. And it is the complete guide to navigating anesthesia and surgery safely and to protect your brain and body. So I want you guys to be looking for that, be excited about it, and it should be going live here in the first quarter of 2026. So stay tuned. Yeah, so glutathione you were saying, is our master antioxidant. That's very important. So if progesterone influences that is a big deal. Yeah, give us some more information on that.
Okay, actually, I did see a paper once, and it was one of the characteristics of the most long-lived people. What they found in common was an abundant natural level of glutathione. Isn't that dazzling? So you do want to pay attention for successful aging. Actually, I could just make a statement about that too. These hormones are so important that their decline brings on all the symptoms of aging that we experience. And for the first time, we can top these things up and have a more vital experience of our lifetime as we age.
100%.
Yeah, how cool is that?
That's it's amazing. The other thing that in the female brain health and hormone and space, when I listen to the big people in that space, I mean, some of them have got it like solid. I mean, I'm not like saying they're all wrong. They're not. There's a lot of people that are getting it really right. But what I hear a lot more is the focus on the estrogen, which, thank God, yes, because estrogen, we know, impacts the neuronal function and the volume of our brain, and the decline of our estrogen directly correlates with the literal volume in our brain. And I know the bioidentical hormones, when we start taking them, I want to quote, I want to say this, but I don't have it in front of me to absolutely be sure that it was a month, but I want to say it was PET scans pre and post bioidentical hormones in 1 month, and they showed volumization of the brain. So of course, rightly, we are focusing a lot on estrogen support and bioidentical hormone space. But the problem is that we miss the progesterone piece, and I can't tell you how many people I know are on Premestrual or some form of estrogen support and no progesterone support. And I would venture to say a large percentage of people, even in the bioidentical world, are getting more estradiol support than they need in ratio to their progesterone, which should be higher, right?
Yes, progesterone should be higher.
And the thing with that is
reversed.
Yeah, yeah. And the thing with that is those people who are like, I mean, I can think of one comment recently on that post. I did a follow-up post on Instagram about sleep drugs, and oh boy, I struck a chord because people really don't sleep in perimenopause, and they're like, well, I don't sleep and I'm already on estrogen. I'm like, well,
Well, that's not doing it.
it's not doing the trick because estrogen doesn't support sleep alone, right? You do need it to sleep, but you need your progesterone primarily because those two hormones fall into the sympathetic hormone versus the parasympathetic hormone. Estrogen dominance gives us sympathetic drive, and progesterone dominance gives us parasympathetic rest and digest drive. So we have to have that right autonomic balance to get our proper sleep when we go through perimenopause. How do we achieve that?
Always start with progesterone. Jerry Lynn Pryor published a book called The Estrogen Storm Season, Perimenopause, and what's really not taken into attention is her work, which she also published elsewhere, that in the perimenopausal years, you have the highest estrogen of your lifespan.
Whoa, wait, say that again. Say it again.
In the perimenopausal years, you have the highest estrogen in your lifespan. Now, obviously, that's not 100%, but that's a high percentage.
It's relative, right? So we call it I say, hey, you're in relative estrogen dominance. What that looks like is you're gaining weight, you're cranky, you're irrational, you can't sleep.
Right. And there's even more to that. So compiled with this is also the tendency during perimenopause to have some shifts up and down with estrogen. And there's a lot of attention paid, like, oh, you need estrogen because you have periods of low estrogen, and this is giving you vasomotor things. And I think we have to rethink that. I heard Jerry Lynn Pryor just interviewed on that, and she said a drop in estrogen will cause a sympathetic surge. Yes, I think
It's
so.
too low.
Yeah, yes, I think so. But I think underlying that really is insulin glucose.
Agreed.
And
That goes back to Katharina's work.
yeah, actually, she recognized that. She put her PMSers on a diet, and she chose complex carbohydrates every 3 hours.
That's right.
I would say
I call
maybe
it the
there's
progesterone diet. That's what I call it.
Yeah, so you that amount of progesterone you need to be handling a drop in glucose, a subsequent surge of adrenaline. Now your body's going to try to protect you from that or balance that with cortisol, with progesterone, with pregnenolone, all of that. But there's another problem that sneaks into here, is that a good proportion of us do not methylate or detoxify via this path of adding a carbon and 3 hydrogens to the molecule. And that failure to methylate well means that when adrenaline has two enzyme systems, one is MAO, which is not used either, there's no drug for it, and really in the natural world there's not much. So methylation is the dominant detox pathway. So if you're unable to get rid of that adrenaline properly by detoxification, it's staying up there. And if you're doing the wearables and stuff, you're like massively sympathetic dominant, and you're staying there. So you have to detoxify, help your body detoxify. So you add methyl groups like methylfolate, methylcobalamin, betaine, trimethylglycine, phosphatidylcholine. It's a precursor to betaine. SAMe are some of the methylators. Use creatine as a supplement because your body will use up methyl groups if you're low on creatine to make it, and then you can't detoxify. So you will need less progesterone to get to comfort if you're helping along this detoxification. Oh, I should not leave one thing out. A physician friend of mine who worked in this arena on adrenaline, he said, this one thing I know for sure. Exercise helps you burn up adrenaline.
Move your body. Sunlight, clean food, move your body.
Yeah.
Mm-hmm.
So every little bit of it helps. So
100%.
now that I've not working in a compounding pharmacy anymore since COVID, I started doing coaching online, kind of like you do. And back when I first started and we were working with PMS patients, we had one tool, progesterone. And it actually worked most of the time as long as the dose was high enough. I'd like to say what some of these doses were.
Yeah,
So we would start at a minimum, and we were compounding capsules in oil, and the starting dose was 100 milligrams 4 times a day.
4 times a day. 4 times a day.
400 milligrams for the day. That was the starting dose, though.
For PMS, not perimenopause, right? PMS.
For PMS. But the symptoms are very much the same, not enough progesterone. So women sometimes use lots more. And they went to other dosage forms too. That's how we started to make vaginal suppositories, rectal solutions, lozenges, creams, gels, what have you, to get the progesterone level up. After a while, I started thinking about this because I said, okay, we get somebody to comfort. We've raised all this progesterone. But what's here on the other side that demanded so much progesterone? And that's where over the last 30 years, we've learned a lot more about the other side. So when I work with somebody, it's pretty comprehensive, like the whole picture. And that's another part of our medical system that we've put people into narrow focus. Like, right. So what kind of doctor do I go to get all these little pieces of information? And they don't exist.
Yeah.
They just do not exist. That's why you have to take over for yourself, gather the information, and implement things that can work.
That's right. That's right. That's amazing. I was sitting there thinking a couple of things. One thing that, as a mama who had 2 children after the age of 35, I think it was 35 and 37 or something when I had my last 2 children. And my youngest has had a lot of detox issues. She had a lot of problems, and she's just she struggles a little bit more. She doesn't pick things up as fast. And I'll be honest, I use a little progesterone on her. I give her a little progesterone. She sleeps amazing.
Yeah.
And so I wanted to, just kind of get your ideas and thoughts about, supporting children through those hormonal imbalances when they come to the world in that deficient state. Probably because, and the thing that I picked up, the reason I started doing that was because of that book that you quoted at the beginning. She was like, the placenta doesn't make as much progesterone, and that's also why we have more nausea and discomfort and postpartum depression in our 35 plus old women who are having children at that age, because they're already their progesterone is already low, and the placenta is making less progesterone as well. And so that's all tied to that. And so I started thinking, okay, well, if there's an IQ connection there, I mean, what's going to hurt my daughter?
No, I am saying this over and over
She
again.
pulls up her belly. Put it on, Mom.
Yeah, there should be an optimal area of how high your progesterone should get. But let me just put this into context. And some of this information, somebody just sent me an article out of the blue, and she worked with an infertility clinic and used progesterone throughout her pregnancies. She had 3 healthy boys. And this clinic actually did a study using extra progesterone with women who were in the normal levels compared to some that were not supported with extra progesterone, and they had better pregnancies, healthier kids, etc. But let me put you in context. So in the normal luteal phase for women, you would produce 20, maybe even as much as 30 nanograms per deciliter progesterone at its peak. Then when you get pregnant, the textbooks go all the way to 200, although that's kind of a mystery too, because I saw one lab had a range all the way up to 500. But then with this study that she sent me, they tested the level of progesterone in the fetus, and it was 6 times the level of the progesterone in the mom.
Whoa.
So let me tell you, when you're giving your young child progesterone, nothing's safer.
Amazing.
Isn't it?
Well,
It's staggering.
I scientifically thought that, and I was like, I trust the biochemistry here more than I trust the double-blind placebo-controlled studies that don't exist because they're just too slow to get them out. This is the kind of stuff that we're, so I'm just going to trust what is logically available science, and go back. Like, you made a great point when you were saying how you started. You learn all this stuff and training, and then as you graduate into your professional, I guess pharmacy, that you kind of learn protocols, if this, if that. Same thing. I'm sorry, but same thing in medical school. I remember, that's why I called this the Rethink It podcast, because I had to rethink. I remember going to a holistic conference when I first started this journey, and they put up the Krebs cycle, and I was like, I saw that like so long ago, way before medical, like PA school, way ago. And these guys rattling it off, and all the cofactors and all the vitamins that are needed. And I'm like, whoa, I didn't know that. And then I was like, what else is it that I don't know? And that's why you're getting outcomes, because you're supporting the mitochondria at the Krebs cycle. Well, this is medicine. I mean, I hate to say it. Well, it's not medicine, because medicine is pharmaceutical. So this is what health support looks like.
Yep, exactly. I remember that too. I had to memorize that cycle, and not until much later did I understand how important every little piece of it was, and one piece missing, and you're having trouble with your own energy production. 100%. So it's huge, just a huge thing. I wanted to go back to insulin resistance, because I'm finding that this is uniformly a big problem with almost everybody I consult with.
Perimenopause, 35 and on.
And I'm not sure. I think I need to do a deeper dive on why exactly that happens. There's a number of things that can contribute. But I sat down on the weekend, and I wanted to put everything I've learned that would help make your insulin more sensitive.
Mm-hmm.
And that's the goal, right?
Mm-hmm.
And it's sort of going to be a never-ending project. I thought blog, but now I'm thinking I need to do a whole ebook or something on this, because it also includes a lot of things that you never hear from any other medical practitioner. So I would like to focus in on, I always say progesterone and something, and I used to Google, and now I'm using more AI to find that interaction with progesterone. Progesterone, of course, does help with insulin sensitivity. Even better if you're low on estrogen and that's combined. Even better, making sure DHEA levels, that's got a big influence on your insulin resistance. So why is that bad? Because when your insulin goes up, it's going up because it's unable to signal your cell to uptake glucose, and then glucose comes up abnormally. So your body is literally starving, and so is your brain when you're in this insulin resistant position.
Wow. You got all this energy floating around, but your body can't use it.
Right. Exactly.
Yeah, insulin resistance is absolutely a thing. It's no question. Every woman I see, because I see a lot primarily in my space, that's who I'm working with, is that same, perimenopausal, after menopause woman. Every single one has insulin, some degree of beginning insulin resistance or solid insulin resistance. And certainly if you start your life with PCOS in your 20s, the risk of that is enormous with huge outcomes. The longer you're in insulin resistance, the longer your brain is starving, and the more likelihood of dementia and hypertension, stroke, and heart. We know that. We know that. That's well studied, even in double-blind placebo-controlled studies. So yes, it's a big issue.
Now that you mentioned this again, I would like to point out it was somebody at the University of Washington State, in the pharmacy school, and wrote a series of articles saying this is not proper scientific method, the double-blind crossover placebo-controlled things. He said, N of 1 studies. N means number, and it's one person. And that's indeed what we go through all the time, working with ourselves.
Mm-hmm.
Or if you're in clinical practice and working with something, that's what you're doing with that individual patient. You're giving them a certain protocol to follow, and then it works or it doesn't work, needs to be adjusted. And you constantly do N of 1s.
That is actually something I heard from the stage twice. They were like, precision medicine, the future of medicine is not this double-blind placebo-controlled 20 years waiting for our blah blah outcomes. We are going to be able to utilize active biometric data. Everything is going to be N of 1. Everything.
And that's a true scientific. The true scientific method is exactly that.
Mm-hmm.
So we do that. We perform that on ourselves every day. What works for us, what doesn't work for us.
It makes me think for a second, though. I'm sorry. I'm on a thought pattern here. It makes me think, did we create that double-blind placebo control study thing because of medications? Because when you give somebody a medication, a prescription drug that is synthetic, then you actually do want to see, does it target and give us an outcome to validate this foreign substance that we're giving the body? Does that make sense? Why else would we have started double-blind placebo control studies?
Once I read an article, this was actually established by a graduate student who made it up as a joke.
What? What do you mean?
He made it up. And then all of a sudden, the people took it up as a logical thing to do.
He made up the double-blind placebo control thing as a joke?
Yeah.
What do you mean? Sorry,
The whole concept. The whole concept. We didn't have any idea like that before.
What?
Yeah, there was a time.
Yeah, there was a time when we were doing N of 1.
That's right.
And we decided this was going to be really the way we should do things and validate our drugs. And then now we're
it's so bad. There was a study that actually had progesterone in its arm in the luteal phase. It was 200 milligrams. And I contacted the head investigator, the one who you could contact. So they were giving women in this one arm cyclical progesterone. And so my question to her was, did they bleed or did they not bleed? Well, because if they bled regularly, that would be a good amount of progesterone for them, right? You know what? She didn't know.
What? What? That is insane.
It's a very famous study.
That's insane. Yeah, Lisa Mosconi, who wrote XX Brain, she does a really nice job in her intro. I don't always agree with everything because she kind of believes that you take your hormones for a short period of time and then stop them, which I don't tend to agree. I tend to agree that women need hormones for the rest of their life, period, and full stop. But I respect her writing, and one of the things that she really did do an amazing job of doing is explaining the history of trials. Because of thalidomide, and this is the story, because of thalidomide, it was given, for nausea during pregnancy, right? Correct me if I'm wrong. And as a result, we saw these horrific congenital abnormalities develop in these kids that were born to mothers who took it. And so as a result of that, the medical establishment said, okay, women should not be included in any medical trials. This is too dangerous. And so it took women out of medical trials, all medical trials. So every drug that came through and was tested was only tested on men. So normal meant male.
Okay? That's right.
And then in the AIDS epidemic, there was a little bit of a push during the 70s. Women started to go into medical school. There was that happening. And then the AIDS epidemic happened, and they were doing experimental medications for AIDS, and women wanted access to those. But because women were excluded from medical trials, they couldn't get access. And so the push from women plus the doctors who were female in the industry caused a change in the governmental regulation of that, and then we started to include women again. But we decided to make them genderless studies. So meaning we did not, what this means is we don't recognize the complexity and individuality of females. So we just group them all together, and we test the drug against women and men, and don't care if we don't say that they're male or female. We just say subject A, B, C. It doesn't matter if it's male or female. Meanwhile, women have 1,098 more genes than men.
Oh, I didn't know.
Involved in hormone regulation and drug metabolism, but we're doing genderless trials, right? And so that has its own complexity because we're not acknowledging the impact that our genes play on our genes and our hormones and all that stuff on how drugs are metabolized. And then the classic example of that would be Ambien. And Ambien, with this genderless trial, approach to studies, we were dosing women by double for 20 years until there were so many incidents of complications from the dosing, like sleepwalking, sleep paralysis, losing time, driving the car not knowing, crashing, dying, so many things. They revisited it and went, oh, women only need half the dose 20 years later. And this is the complicated, but this is where we are now. We are still in genderless trials. To do gender-specific trials where we say women get this, let's say Ambien 5 milligrams, and men get Ambien 5 milligrams. We study each group separately and see what the right thing for them is. That would cost twice as much money, so they're not doing it, right? So that's where we are in medicine, and that's just it's just crazy to me.
And the other thing is all these chemicals. We reward industries for making strange chemicals that were never found on Earth before.
Exactly.
And so when you put that in a human body, that's actually the study of pharmaceutics is like, what's that drug doing in your body? I was sort of interested in that, but we have no way of knowing.
That's right.
There's no way we can understand the implications of a foreign chemical in our body.
Right.
And so I think women in part were actually on the lucky side when they weren't testing them, because it spared women a lot of chemicals that
really well said. Yeah.
Yeah. And I'm thinking that about animals too. We torture animals and for sake of science. I think it's wrong.
I agree. Yeah, I've been pointing out and getting a lot of exposure and I'm not trying to demonize pharmaceuticals. I think they have a place, and thank goodness we can use some of these medications as bridges for things, but they should be bridges. I've been getting attention because I did this post about the 4 drugs that included fluoride that people didn't know. And it's in more things than you could think of: albuterol, Flonase, Lipitor.
Yes, and the drugs.
SSRI. Prozac. Yes, correct. Prozac and Paxil. Here's a drug that we're trying to give you to help you out of depression while it's literally calcifying your pineal gland in your brain, which is your center of like intuition, I mean, every Eastern practice understands the pineal gland as your connection with the universe, like,
Yep.
or
Yep.
your divine connection. And there's a reason it's called your third eye. But, if we're going to go real scientific, it's the place where we make melatonin, and it's a really important part of your brain, so, if we stay Western completely on that science, but it's horrible. And the fluoride literally impacts that. And, people were shocked, but why would you be shocked? Another thing that, I discovered it was like, okay, hold on. My son's 24. It was like 12 years ago. And I posted it on Facebook back then, and I didn't get any people were like, but now I guarantee you people are going to be shocked when I say this. But there are, I don't know every drug, but the ones that I cared about at the time was my son was on Vyvanse for ADHD, and we were weaning him off. And for some reason, I got a wild hair and pulled up the package insert on Vyvanse, and I wanted to see every ingredient in it. And I went down to the bottom, and I would be darned if Lake Blue 1 and Yellow 3, or Blue 3 and Yellow 1, I can't remember, but I think it's Blue 1 and Yellow 3 were in his medication. And I'm like, wait a minute, don't those artificial dyes cause ADHD in kids? Why is it in the ADHD medication? I'm confused. And those are actually being withdrawn from market in our food supply in the next 2
Yes.
years. And here they are in our drugs. And I'm like, what in the
Oh,
world?
can I bring up a more pertinent thing to our discussion on progesterone? So we have an FDA-approved product called Premestrual that I mentioned before, and it has peanut oil in it. It's got 2 dyes in it. It's got titanium oxide in it.
Yeah, they all have titanium oxide in them. Every drug. It seems like every drug. Everyone I look at.
And this happened quite by accident. I was thinking about what side effects they were listing on their FDA-approved insert. And I went to Google and I pulled up Prometrium, and I stopped and looked at the ingredients. I couldn't believe it. I had pulled up Australia Prometrium.
Yeah.
No dyes, no titanium oxide, and sunflower oil. And
You gotta be kidding me.
and
Ridiculous.
as I looked further, the people that own Prometrium also own Utrogestion that's used in Europe. It's the same formula. So Canada, Europe, New Zealand, Australia do not have the same Prometrium we have in the US.
Wow. That's just upsetting. Upsetting your mind.
I go, what the heck?
Right.
So when I was in compounding, we would use
the point you
olive oil and progesterone, even
Wow.
colorless capsules, so you don't get any stuff in the capsule.
So can people?
It doesn't have to be that
get every drug compounded? Like, can you get every drug compounded, even the new ones?
You could. One of the things compounding is limited to those drugs that are FDA approved, but you can offer alternative doses and dosage forms for that. One of the things you could very well do it is by saying we're not using any dyes or other fillers to make something as an alternative.
Okay, so let's get back to the progesterone topic. Sorry. Well, it's relevant because you made the point of xenoestrogens. We are paying attention as a population to xenoestrogens in our food, forever chemicals, in our makeup, in our products, but they're in our drugs. Like, they're in our drugs. It's a great point. So the other question I had for you was progesterone. Is it limited to women?
No. And you'd be surprised how much resistance there is to that. So we've been giving men testosterone, and then we give them an aromatase inhibitor. We're using like Arumadex,
Mm-hmm.
which was developed to strip women of estrogen during breast cancer treatments. This is where that drug came. And then even more alarming, so men with premature balding and prostate enlargement are given a drug called finasteride.
Right.
And so all you have to do is go to Wikipedia. They're pretty good for structures. So go to Wikipedia, look up finasteride, and it's Propecia and Proscar. Propecia for young men, Proscar for old men, higher dose.
Mm-hmm.
And this is supposed to be a 5-alpha reductase inhibitor with kind of the mistaken notion that men are turning their testosterone to dihydrotestosterone, and this is causing the problem. It's probably not. There needs to be some balance with progesterone that's lacking here. So progesterone itself is both an aromatase inhibitor, so you don't need the Arumadex. It's also a 5-alpha reductase inhibitor. It's a competitive inhibitor because the enzyme works both on testosterone and progesterone. So losing that. So you look at this drug finasteride.
So that helps us to boost our testosterone levels?
No, it helps control it so you don't go all just in one direction. And then like the progesterone side, and from that 5-alpha reductase, it changes progesterone in 2 steps to allopregnanolone. And this is what we really want for our brain. Allopregnanolone fits on the GABA receptor. Progesterone directly does not. So you need that conversion. So without that conversion, you lose all the calmness that you get with sensitizing the GABA receptor for it. So it's really, really important. So they stick in that drug, which is an altered progesterone molecule, and you can look up progesterone molecule 2 and compare.
So you'll see compare them back to back.
Yeah, you can see how close they are. So with that alteration, they're trying to interfere with that conversion from testosterone to dihydrotestosterone. Is why you take it, so you don't have the excess and stronger androgen effect, which they think is causing the prostate enlargement. I would argue that's probably a pretty good symptom of insulin resistance and probably estrogen dominance. That's what I'm thinking.
Yeah, because I've had patients or clients, male clients who have BPH and those symptoms, and their testosterone is tremendously low. Their dihydrotestosterone is low.
Yeah.
It's not high. And I do use...
So that can be the reason.
Right. Exactly. So that's interesting. So interesting. I hadn't actually looked into those drugs. I didn't even, I've never done urology, didn't have a clue how those drugs worked. I'm like, I don't know, it's a BPH drug. So that's a really interesting explanation.
It's a fake progesterone. So
wow.
So if you keep that in mind, why not use progesterone? So this is really serious. There's a website, propetiahelp.ca, and the side effects of that molecule is tremendous. You can lose sexual function, sexual interest, be hugely depressed. There have been suicides because of that drug.
Oh my goodness.
We don't hear about it.
No, we don't.
There's a class action lawsuit going on.
Wow.
So why not use the real molecule?
Again, peel it back. We're just trying to synthesize what's happening in nature with pharmaceuticals so that we can...
how much progesterone should men have?
That's a good question.
We spoke earlier about the follicular phase, and I said it should be up 1,000 from that normal chart. But men have the same. It's primarily...
Wow.
The follicular level is primarily adrenal progesterone, and it should be quite high. Wow. If you put it in the same units. I believe men have more testosterone than progesterone. Progesterone's second. And a small amount is made in the testes, and it's a precursor to testosterone in the testes.
Yeah. Right.
So there's that pathway too. So I started a Facebook group called Progesterone for Men.
Mm-hmm.
and be delighted to have men or women.
Yeah.
Women usually know a man that they're
Usually the
considered.
women advocating for their men.
I know.
That's the other problem in perimenopause is we carry the weight of the world. We are nurturers of our families. We're creative, we're industrious, we're business women a lot of times, and we're also mama who gets everything done at home. And I don't know. I'm just speaking about my life. Like my kids call me Dr. Mama because because they know that if they're sick, that mama's gonna get them well, like
Uh-huh.
tomorrow, right? And
Oh,
boys are home, oh no, like so it adds a added level of stress when our brains aren't working, and I loved what Sarah, I don't know her last name, Schall now I think it was, but it was Gottfried when I read her book,
yeah.
said about, we stop giving a crap in our 40s because of a decline in estrogen, which is our nurturing hormone. And so you start to actually kind of get a little bit on that bitterness side, which is not good for our emotional health and our mental health either. Do you know hormones influence everything? It's this mind, body, spirit. It's a big deal.
It's huge. I had a client who was using 600 milligrams of progesterone at the time. And she said, nothing my husband says bothers me anymore.
Wow.
Whoa.
Wow. Yeah.
The impact, not only your spouse or maybe your children, it's your relationships throughout your world.
Right.
If you get to be like you can't handle any sensitivities, you don't have the hormone milieu that
You don't
allows you to.
have the resilience, the
Right,
hormonal resilience to handle anything. How can you
right.
step out into anything and handle more stress? Yeah, that's amazing, and that's a really good point.
This is, yeah.
Yeah,
So you're absolutely right. This causes a lot of problems in families and
yeah,
in work settings and everything.
100%. Women crash and burn in their 40s. They crash and burn for many reasons, but a big piece of it is that hormonal imbalance. It's the imbalance, and it starts with progesterone, which, and the last piece I wanted to highlight that I thought was super important. I think we got cut off because of our tech problems earlier on, and I'm going backwards a little bit because it's not in the good flow of our conversation, but I have to say it, that heavy metals down-regulate our progesterone. They block our progesterone receptors. We were talking about that, and I wanted just to point that out because this is why when you're looking at your health and your issues and your hormones, you got to look at the whole picture. You don't just go, is it just my hormones? You got to look at toxic burden. Do you have heavy metals? I had a client a couple of months ago. I couldn't believe how many heavy metals were in her body. It's hard to find those on urine, and she had like 5 of them, and they were really high. Of course she felt like crap.
Yeah, and it's not only sitting on a progesterone receptor. There's they call it metalloestrogens, such as cadmium will sit on an estrogen receptor.
Wow.
So
So it's xenoestrogen and it's blocking progesterone.
yeah, so heavy metals cause a lot of problems
Yeah.
with your endocrine system.
I think we've covered the gamut here. And I
Okay.
would really want to talk. I want to talk for like another hour because I love talking to you because you are like an encyclopedia when it comes to hormones. And I don't think we even really touched the iceberg on progesterone. I really encourage everybody to check Carol Peterson out. She has a website. All the information for finding her is on her website and will be in the show notes. I'm sorry, all the information to finding her is going to be on the show notes, and all the information kind of we talked about. She is a wealth of resources. So I would definitely check that out. Is there anything last minute that you want to leave the audience with on anything we talked about today?
Okay, I want to say one more thing. So it's also kind of driven into us as we age, and that we can't expect to feel good. I'm going to say don't settle.
Amen.
And if you can get so much benefit from hormones, and this is not an all or nothing. You could feel 80% better seek out that extra 20%. You're missing a little bit, and grab for everything, and don't settle for anybody telling you you're just
This is
aging and
just
that's
it.
normal. Yeah.
This is normal. Remember,
Yeah.
normal means male.
And normal is like all of us, sick people included, as well as
Exactly. Don't settle for just living and surviving. Let's work to be thriving.
right.
Yeah. Amazing. So great.
Thank you, Sandy.
Thank you so much, Carol, for coming on. I really enjoyed the conversation.
Me too.
Well, thanks again for listening in today to the Rethink It podcast, where we are changing the way the world sees brain health, one conversation at a time. If today's episode made you pause and think a little differently, be sure to share it with a friend who's also ready to take charge of their health and healing. You can find more resources, guides, and even my upcoming book, The Quick Way Back, which is going to be your complete guide to protecting your brain and heal faster after anesthesia, all at my website at beyondbrainhealth.com, because your brain was designed to heal, and together we're helping it do just that. And don't forget to follow, like, and subscribe so you never miss an episode. And in closing, please remember, stay curious, stay grounded, and stay empowered.